Hi, everyone. Welcome. I'm Charles Davis, the Dean of the Grady College of Journalism and Mass Communication at the University of Georgia, and we're all delighted that you could join us today for Ask Me Anything with one of my favorite faculty members, Dr. Glen Nowak. More about Dr. Nowak in just a second. A word or two about me. I joined UGA in 2013 after a long career in both print journalism and journalism education. I came to UGA from the University of Missouri, where I was 14 years, a faculty member and administrator there before coming home to Grady. Grady was my academic home as a graduate student many years ago, and Athens is my hometown. So in many ways, I got to come home. It's now my great pleasure to say a word or two about the college and then turn things over to Dr. Nowak. Grady College has about 1,500 students, 1,300 of them undergraduate, and a little bit north of 100 graduate students. We have master's and doctoral students in the college studying a number of things. We have three disciplines in the college, well, really four disciplines in the college: advertising and public relations, journalism, and entertainment and media studies. We have faculty across all of those disciplines studying a wide array of topics, everything from sports media to today's topic, health and risk communication. So we are pleased today to have, I would say, the foremost health communication scholar in America, Dr. Glen Nowak, as our guest. Dr. Nowak is a professor of advertising and public relations and director of the Center for Health and Risk Communication at Grady College. Prior to rejoining the Grady faculty, he spent nearly 6 years at the 14 years at the Centers for Disease Control, 6 as Director of Media Relations at the CDC, and 6 as Communications Director of the CDC's National Immunization Program. He, he's published countless articles on health communication and has an international reputation as an expert on the subject. So it's a real treat for us to be able to turn to Dr. Nowak in a time in which interest in his topic could not possibly be greater. Dr. Nowak, welcome.
Well, thank you. And thank you for the invitation to be part of this. And I will see if I can bring up my slides. So as Dean Davis alluded to, I'm going to talk about public health and news media and COVID-19 and some of the things that make communications so hard and some of the things that we have learned can make communications about things like this go better. As Dean Davis alluded to, my background includes working at the Centers for Disease Control Prevention. I actually started at the University of Georgia back in 1989. And from 1989 to 1998, I was an assistant and an associate professor of advertising and public relations at Georgia. And during that time period, I spent a lot of my time going back and forth between Athens and Atlanta, working with the CDC's Division of HIV/AIDS as a visiting communications scientist on a wide range of communications projects involving another infectious disease, HIV/AIDS. And my projects there, the projects I worked on there, ranged from helping them better understand how people understood their HIV public service announcements for their HIV hotline to a large conference on the use of entertainment education for HIV prevention among youth. And then in 1999, I was offered the opportunity to join the CDC as the first director of communications for its national immunization program. The immunization program was one of the largest programs at CDC, it still is. It was one of the last to have an office of communications, and so I was asked to build that office of communications. And I left the University of Georgia to undertake that task in January of 1999. And in 2005, I was asked by Dr. Julie Gerberding, who was the director of the CDC at the time, if I would consider coming over to become the acting director of media relations. So I took on that assignment, first on a temporary basis, and then I decided to apply for the permanent position, and I was selected to become the director of media relations at CDC. And so I served in that position for 6 years, including during the 2009 H1N1 pandemic. And then in 2012, I decided I had been on call 6 years, been on call 24 hours a day, 7 days a week, for 6 years, and it was time to find something that would still keep me in the communication space, but not quite that much. And so I became the Senior Health Communication Advisor to the Director of the National Center for Immunization and Respiratory Diseases, a woman named Ann Schuckett. Today, Ann is the Principal Deputy Director of CDC. And then in 2013, I rejoined the faculty at the Grady College, becoming a professor of advertising again and a director of the Center for Health and Risk Communications. Since 2013, I've been heavily involved in a lot of different projects. I currently serve on a Department of Health and Human Services National Vaccine Advisory Committee Working Group on Vaccine Confidence. I have been a visiting communication scientist with the National Vaccine Program Office at the U.S. Department of Health and Human Services for about a year. I have served as a senior communications consultant to the Sabin Vaccine Institute, where we have been working to develop a global vaccination acceptance research network. In 2014, 2015, I got involved in a project helping the World Health Organization, the Task Force for Global Health, UNICEF, and others develop a communications plan for a major event that happened in 2016. 130 countries simultaneously switched from using oral polio vaccine to inactivated polio vaccine. I've been involved with some of my Grady colleagues, including Mike Cacciatore, on national surveys of US adults, including related to adult vaccine knowledge and acceptance, which included their health decision-making preferences. And I've also have co-authored 2 chapters for a forthcoming book on communicating about risks and safe use of medicines, real life and applied research. One of the chapters is with Professor Cacciatore on media science, and another one is on lessons learned from the 2009 H1N1 pandemic. One of the other things I've done recently is I've worked with some former colleagues at CDC, Abigail Tumpy and David Daigle, and we were asked to write the updated chapter on communicating during an outbreak or public health investigation for the CDC Field Epidemiology Manual, which was published in December. And that manual is one of the key documents or books that is given to the epidemiologists who are dealing with infectious disease outbreaks. And our chapter provides them with guidance about how to communicate. And as you can see here, before an outbreak is recognized and the investigation begins, we often don't know how many people have been exposed to a health risk, including without experiencing illness. As the number of people who are exposed to the risk or become ill increases, you become more aware of the problem. But even then, at the beginning of an outbreak investigation, there's a lot of uncertainty, but there's also a lot of interest and there's a lot of need to communicate about it. What CDC has learned from outbreak communications is that there are certain key concepts that really help, and there are key concepts that really help determine how effective your messaging is going to be. One of the most important is that you have to have trust and credibility. If you aren't trusted, you aren't seen as credible by those to whom you're offering advice and guidance, your communications will likely not succeed. And again, a lot of times people forget that it's not just about informing, it's about persuading. You have to persuade people to follow your public health recommendations during an outbreak or a response. And you often need to get them to do that relatively fast. The actions and behaviors of those who provide leadership and expertise and advice matter. Sometimes we forget about that and we think it's mostly about messaging, but the actions and behaviors of those who are in the public eye often matter more than words. And so their actions need to be consistent with what they're telling people to do. Messages and information need to resonate. That is, they need to be understandable and relevant to people in the affected groups. And what that means is that it's often communications efforts are going to be more complicated than many people imagine. They're going to require community engagement and the involvement of people trusted by the groups that you're trying to talk to and inform. As we're seeing with COVID-19, communication strategies and plans need to be adaptable and flexible. They're going to have to change and evolve as the situation evolves and as more is learned. And then trust and credibility of those who are offering advice, who are offering leadership, is often affected by how they come across in terms of empathy and caring. They need to be seen as empathetic and caring, and it has to be genuine. Honesty and openness matter. Dedication and commitment, including to helping people in the affected groups, and then competence and expertise. So all 4 of those things come into play. And in organizations and spokespeople who issue messages and information, they need to convey those 4 factors. And if they are able to successfully do that, they're more likely to maintain and build trust in a crisis. With respect to COVID-19, one of the activities I've been involved with over the past few months is helping some other risk communications experts develop simple answers to top questions. And this document, which is made and provided by the Association of State and Territorial Health Officials, is now in its 4th edition. The first edition was written in February. It's constantly evolving. It now has over 50 questions that have answers related to COVID. It's got a well-indexed table of contents, and it's available absolutely free to anybody who would like to get it. And that website is at the top of this slide. One of the most difficult things for scientists, for doctors, for even politicians, those who are involved in trying to persuade people to do something, is it's often much more difficult than many people realize. In fact, what people often imagine is something like this. There's a group of people who are not doing a recommended behavior, and the belief typically is that we just simply need to provide them with information and advice. And that information and advice, if it comes from an expert, will really make a big difference. And an example would be experts have been saying to people who don't get a flu shot for decades, don't get the flu, don't spread the flu, get vaccinated. We know from lots of research that that's had some effect, but not exactly a great effect. And so we don't get what people think, which is that if I just provide information and advice from an expert, I will get immediate widespread behavior change. Rather, we get something typically much more modest. And the reason we get something much more modest is that information by itself, particularly factual information, is rarely enough to influence or motivate people when it comes to their behavior. With respect to COVID-19, March 11th was a key day. The World Health Organization declared a pandemic. And as I mentioned, empathy is one of the key parts of risk communications, and they pointed out that they were deeply concerned, both by the alarming levels of spread and the severity, and the alarming levels of inaction. And oftentimes, one of the key parts of health communications or risk communications is getting people to take action, getting people to worry. Many times people will talk about panic. Panic is exceptionally rare, and it's often not the thing that happens. What happens instead is apathy and denial, and those are the bigger challenges. So you have to get people engaged, and one way that sometimes is used is to get people to understand that we are now at a different level, and pandemic is the ultimate level. When you declare something a pandemic, it has major implications for health, for economies, for society, and for how we respond and who needs to respond. Today, the CDC put out a special report. Every Thursday, they have a weekly report called the Morbidity and Mortality Weekly Report. Today, they put out an article in advance of that. And this article gives you a sense of what we've been seeing is that COVID-19 is very serious and it easily spreads. And what this report highlights is that way back in March, there was a case, an outbreak in Seattle, and it was an outbreak, one infectious person infected 61 other people. And so COVID-19 spreads easily. One of the biggest challenges, and that's the reason that you see recommendations like avoiding groups, staying at least 6 feet apart, and wearing face coverings. There's been a lot of work in the science of risk communications about what makes risks more challenging to communicate, and what makes risk cause people to be more fearful. And as this little diagram shows, is that COVID-19 and this new coronavirus are in the corner that is the most problematic. You're talking about something that's not observable, it's unknown to those who are exposed, the effects are delayed, it's a new risk, much of the risk is unknown to science, and as a result, the threat is uncontrollable, there's a lot of dread, there's global catastrophe. That's probably the worst case scenario when it comes to health communications and the health issue. We have seen in the last couple months that there are many health communications challenges when it comes to infectious diseases. We have seen lots of uncertainty. The uncertainties are many, they're continuous. They involve the virus, they involve the disease, they involve testing, they involve treatment, they involve what to do with test results. The knowledge that we have, the recommendations that are being provided are regularly changing, and they're often changing quite quickly. There are many experts who have weighed in, and they come from a variety of disciplines with a wide range of expertise. They are often offering different and competing views and competing recommendations. We have seen, particularly in the last month, the communications challenges related to populations. States, communities, countries represent diverse populations. And when you look at a diverse population, you see lots of differences. There are generational differences in how this disease and how the threat is playing out. There are gender differences, there are race and ethnicity differences, cultural differences. There are different moral values and priorities that come into play. There are different political affiliations and ideologies that come into play. And from a communications perspective, those things matter, and they matter a lot. Individuals and groups, particularly those who are dissatisfied with government and public health measures, are often quick to visibly, aggressively, and persistently voice their preferences and objections. It can be really hard to make sense of all that's going on because there's a lot of information, there's a lot of views. You can turn to sources everywhere. There's misinformation, incomplete information, disinformation, and rumors. And then we're also finding, and this is something that those of us who know and have done health communications know, is that there's a lot of attention on risk perception and trying to use communications to influence people's perceptions of risk, to get them to understand how severe something is or how susceptible they could be. But I think what COVID-19 has also done is serve as a reminder that it's not just about perceptions, that there are actual true differences among people when it comes to things like risk tolerance and risk acceptance. And those things vary widely by individual. And so it's not just a matter of changing people's perception. If they do not believe, or they believe that they can tolerate a risk, changing their perceptions may not be as helpful as one would imagine. So thinking about how do you do risk communications and how do you do COVID-19 successful health communications? Well, I think some of the principles that you have to apply are, first and foremost, you have to know what it is your overall objective is. And what outcome are you striving to achieve? Are you trying to get everyone to take actions, such as social distancing, to help slow the spread of COVID-19 and protect older adults from severe illness, which is probably what many are trying to do? That gives you direction. And so you have to know what your overall objectives are. Oftentimes, communications objectives need to be focused around setting, guiding, and managing expectations. So it's not just a matter of increasing knowledge and awareness or changing beliefs, but you actually have to use communications and think about what expectations are my messages setting, and are those expectations realistic and appropriate? We know from a lot of emergencies and crises that risk communications principles do increase the likelihood that you will be able to achieve your overall communications objectives. And when it comes to risk communications principles, the ones that often are at the forefront are expressing genuine empathy and concern for those who are affected, acknowledging the uncertainties and where those uncertainties exist and how they come into play, sharing dilemmas. There is rarely in an emergency one single obvious solution. Rather, there are lots of possibilities, and we're seeing this now with opening up, none of which have, all of which have strengths and weaknesses. You need to foreshadow possibilities, including the likelihood of things changing and the ways they could change. And then you need to level with people regarding the value, the limits, and the basis for actions. Particularly the limits. People get skeptical if they think that what you're promising or what you're saying is unlikely to be achieved. Communications need to revolve around trusted and credible spokespeople, and those may be different for different groups, but those spokespeople and those experts need to be continuously highly visible. We are clearly in an era where websites, social media, e-health, mobile apps play essential communication roles, but they need to be well-resourced, well-designed, and continuously updated to be helpful. We need professional organizations to be actively involved in providing expertise access to experts, advice, recommendations, and resources. Many journalists in the last couple of months have found it very difficult sometimes to get access to experts, particularly frontline healthcare providers. And in messaging is essential, but I think people often underestimate how long and how many messages are needed. And so oftentimes government agencies and other organizations find they need health communications campaign and messaging assistance because there is such demand for messages. We are at a state today where we're seeing states and communities open up. And as a result, one of the dilemmas is reflected in this question somebody wrote to a advice columnist on Market Watch, saying my state's reopening restaurants and movie theaters. Am I selfish if I go, or am I selfish if I stay home? And in looking at the person who answered, who provided advice, I thought did a really good job of recognizing there is no one answer. And as his answer to this question included, I think, 3 really important messages. We're going to find going forward that there is no one-size-fits-all answer to a lot of things involving COVID-19. We are going to learn that if infections start rising and more people start dying, then that's going to have significant implications. And some of the economic recovery and some of the businesses will have to, again, take a step backwards. And then ultimately, we're responsible for our own actions. And we also are responsible for each other. And that's going to be a challenge for each one of us going forward, that we have to make decisions that not only involve us, but they will affect other people. And so as part of messaging going forward, I would expect we will all see these kinds of themes in a lot of the COVID-19 messages going forward. Going forward, for kind of summary points, it's going to continue to be challenging. The only certainty that come with infectious diseases, particularly new ones, is continued uncertainty. I learned when I was at the Centers for Disease Control and Prevention that was true even with influenza, that you did not know at the start of an influenza season how that influenza season was going to play out, how long it would be, how severe it would be, and when the peaks and valleys would arrive. COVID-19 communications should be grounded as people develop communications plans going forward in expectations and remembering to set appropriate and realistic expectations. One of the expectations that is often can get people, one of the challenges when it comes to expectations, I should say, is safety. I've seen some people trying to put out messages saying, we can ensure your safety. Nobody can ensure somebody's safety. And that's an example of where things get really challenging, because safety is not something that can typically be guaranteed. Policies and actions, including how they were developed, affects communication success. And so if I'm a communications person, it's a lot easier to be successful if there is support for a policy. And where does support for a policy come? It comes from when that policy is being developed, listening, dialogue, and engagement. And then messages and guidance need to account for fear and frustration and avoid being dismissive of fear and frustration. Our messages and guidance going forward need to foster understanding and patience in the face of much uncertainty. We need to model and facilitate coping. And ultimately, we need to offer support, encouragement, and hope through our communications and actions. And so that's kind of a relatively quick overview. And with that, I will turn it back to Dean Davis.
Great. Thanks, Glenn. That was really interesting. I have a couple of questions. I'm going to play my moderator role, and then we'll take some from the audience. So please feel free to use that Q&A feature and send your questions in. But as an opener, what is different or unique about COVID-19 and communicating in COVID-19 as compared to the other pandemics and crises that you've stepped through as a communicator?
Well, one of the biggest differences is it involves an infectious disease that we have very little experience with. When I was at the CDC in 2009 and we had an H1N1 influenza pandemic, we had considerable experience. Meaning the agency had considerable experience with influenza. We had the advantage of knowing that we would have a vaccine. And we knew that it was just a matter of time. And unfortunately, back then, time was a challenge because most of the flu vaccine in the country was made using chicken eggs. And as a result, it was a 6-month process. And so even though we knew we would have a vaccine, we were challenged by it was going to be 6 months before we had it. With COVID-19 and this new coronavirus, we don't have a vaccine. We don't know if we will have a vaccine. There are a lot of efforts underway to develop a vaccine, but a vaccine is not a guarantee. And there are circumstances, there are other infectious diseases where people wanted vaccines, still want vaccines, and decades later, we don't have vaccines. And so I think one of the biggest unknowns is what are we going to, when will we have a vaccine, and what does that, how effective will that vaccine be? I think another big difference is treatment. We are now trying to also figure out what is the best way to treat people. And as we're learning, this COVID-19 illness has been playing out in terms of symptoms in a lot of different ways. And I think that's not something we've ever seen before or experienced. It's a lot easier if there's a distinct set of symptoms and a pretty consistent course of illness. None of that seems to be in play here. So that makes it much more challenging to communicate. And I think finally, the fact that like a lot of infectious diseases, it's playing out differently in different parts of the United States and different places in a given state. And it's just hard to come up with one size fits all actions and recommendations.
Right. We noticed that state leaders started with a primary message. That message was always stay home, self-distance. And then later, they began introducing more nuanced messaging, wear masks, for example. How much does the nuance of a message impact the way in which it's communicated?
Well, the nuance is a challenge. People want black and white. People want, it's either red or green. And I think nuanced messages are really difficult. They're difficult because the nuances may not get conveyed consistently. They can get dropped as people share information from one source to another. Nuances may not be well understood. And so face masks is a good example of many things. Face masks are a good example of what happens when you take a really strong position at the outset, where you say they're not needed by everyday people, and then you change your position 6-7 weeks later and say, well, you know what, we think they're a good idea. And so that's one challenge. I think the other challenge with face masks is the bar. How long do you stay with the recommendation that people should wear face masks? Infectious diseases are with us in general. And if we really believe that a face mask or a face protection is a useful tool, does that mean that they're a useful tool going forward forever? And that's kind of, I think, hard for a lot of people to believe that that is a good idea or that they want to do that. And so I think it's important, I think, that as this recommendation is out there, that there's also science being done to take a hard look at the value added of face protections and where is it greatest, when is it most, and when is it not so much. Because at the end of the day, you also can create the illusion of a false sense of security. Because viruses are really tiny and they do get through the pores and masks, whether you're the person wearing them or you're the person, or whether you're the, whether it's stopping your cough, which is much more effective, or whether you're wearing it in a public setting, but they're not body armor.
Although they can make me feel like I'm breathing through body armor at times. How important, Glenn, is it to be explicit about economic costs and economic trade-offs when communicating about health communication and risk?
I think it's pretty important. In fact, I was looking back a few weeks ago at some of the materials that I had been part of at CDC when we had done pandemic preparedness exercises and some of the messaging that we had developed in the 2009 H1N pandemic. And I was struck by the fact that early on, we recognized that it was important to, as one of our goals, to take into account the societal and economic impact of our public health recommendations. And so we were sensitive at that time that there were ramifications. And one of our goals was to try to make those implications, the negative implications of those things, as small as possible. And I think, again, ultimately this involves trade-offs, and there's no one right answer. And I think, again, it's going to be important for public discourse, public engagement, community engagement about, going forward, what are the priorities if we're going to have to coexist with this virus for a while.
Mhm. Here's a really interesting question. As a community member, how can I encourage trust in the expert's advice among many in my circle with strong distrust of government, big pharma, et cetera, et cetera?
A very good question, and there's not an easy answer, unfortunately. In fact, I face this same challenge in my family. I have a brother who is deeply distrustful of the government, and deeply distrustful of experts. And I guess it requires patience and listening. It requires, I think, finding examples that they can relate to. And that can be a challenge, but I think finding examples based on their values, the things that they can relate to, can help. Being able to look at, one of the things I do, I spend a lot of time is I look at comment sections to see how people are trying to respond to the critical comments of others, and looking for different ways that people are framing things and talking about things. I think, again, there is the recognition, experts aren't always right. And I think sometimes one of the things that people are responding to is that experts often are wrong, and I think skepticism is bred by things like telling people masks aren't necessary, and then 6 weeks later saying, well, I think you ought to use one. And so for people who are skeptical, those kinds of examples. So I think the experts have to play a role in this too, by acknowledging the limitations of their knowledge and sharing dilemmas. I mean, letting people know that, that we don't have a good solution, and that the solutions that we're offering do have drawbacks. But we think that, at least in the short term, the drawbacks that they have are outweighed by the benefits of what we're recommending.
This is also a really interesting question, I think. How should higher ed effectively communicate the realities of a current student's experience to prospective students during this time?
How should higher?
That's a tough one.
It is a tough one, and I think so. So one of my general philosophies when I was at CDC was my recommendation to everybody was I would default to the truth. And if I default to the truth, I think what you're going to do is going to be honest. You're going to say that we don't know. I mean, right now we are in a unique time. It's an unprecedented time, and it is a challenging time. And the typical experience of students coming in the fall is going to be atypical. It is not going to be what they expected. It's not going to be what we expected. It's not going to be what either of us want. That said, I think we all believe it's a temporary situation, and we will get to the other side of this sooner or later, hopefully sooner. And I think there are advances that are being made every single day in terms of treatment and testing that will help us learn things over the next few months that will have much relevance in terms of how we're able to operate and how we're able to open things up. I think we're going to learn things from all the different things that are happening across the United States and the world in terms of different communities trying different things. So in some parts of the world, they are opening schools up. And I think we're going to see from those experiences what happens. How are there outbreaks? Are there cases? What happens when there are? How far can we go in terms of opening things up before we run into challenges posed by the virus? All right. So I think my advice would be, I think, to look at it with not so much that this is awful, but we're on an adventure. And yes, there's adversity, but I think a lot of times people will tell you that, there's going to be adversity in life. And one of the things you have to do when faced with adversity is figure out how to cope in the face of adversity, figure out how to be resilient, figure out how to be flexible. Those are life skills that will benefit you in the long run.
How do you counter narratives? There are a lot of people out there, anti-vax folks, people that are telling people on YouTube that if they drink bleach, they'll get better. To what extent do you take counter narratives into account in forming health communications?
Well, I think one of the challenges that public health and scientists and doctors are always going to have when it comes to people who are putting forward competing narratives is that they have much more creative freedom, and they know it. And so whereas scientists, public health, and others are constrained by science and by facts, and can't just go and run with other things. That's one of the handicaps, is that those who are opposed often can go in more directions and say things that may or may not be true, and assert them confidently. And that's going to be a challenge. How do you counter that? I think you counter that with a unified front, that you have to engage a wide spectrum of people in that effort. You have to engage a wide spectrum of influential people in that effort. Those influential people may not always be doctors and scientists. Sometimes we learned in the world of immunization, nurses were often much more influential with groups who were skeptical, with parents who were skeptical, than a doctor was. And so it's finding those other groups. It's actually sitting down, I think, and engaging with them. One of the projects I had at CDC was, we did a project in 4 communities across the country, and it had to do with whether we should expand a recommendation for using a vaccine, adding it to the childhood immunization schedule. And we went out to communities and we invited people from across the spectrum. But rather than talk at those people across the spectrum, we broke them out into small breakout groups and we had them talk with each other. And I think that was really helpful in terms of advancing understanding. It was, rather than the experts talking to people who had different beliefs, it was providing an environment where you could have a productive conversation with people who had different beliefs. And I think, trying to figure out how you can do that. And I think we also have to become better storytellers ourselves. I think one of the challenges is we think that the facts speak for themselves, that statistics speak for themselves. And I think we have to surface people who have been affected by this virus, who have been affected by COVID-19, the illness, and who have recovered, or who are on the front lines, and who can tell their story, and making those stories as prominent.
Yeah, it's a really good point, because it's hard to deal with disinformation and misinformation without bringing more attention to disinformation and misinformation.
And I think one of the other challenges, when you see the public opinion polls are showing 75, 80% of Americans in some cases believe that we're moving too quickly and are supporting the measures that are being taken. But those are not the people who are going to protest and start state capitals. Those are not the people who are going to come out and make noise. And I think that's the other challenge, is that the people who oppose, even if they're a small number, are often very good at getting lots of attention, a disproportionate amount of attention to their size. And I think we all would benefit from trying to keep that in mind, put them in context, including the news media outlets that like to highlight their protests and their actions.
Yes. How do you deal with the change in terminology? In mid-April, the World Health Organization announced a change from social distancing to physical distancing, but it didn't seem to make any difference at all. What happened?
Well, I think the term social distancing has long roots. I was at CDC in the early 2000s, and we would do pandemic preparedness exercises, and we used social distancing. And it was a term that didn't come from the communications people, I don't think. It came from the epidemiologists and the scientists. And in their mind, social distancing was synonymous with physical distancing. But they thought that it was a better term because it referred to the fact that when people were together, it was often in a social circumstance. And so they were trying to convey the fact that you shouldn't bring yourselves together in close proximity. What we have seen, I think, is that a better term probably is physical distancing, because we don't want people to lose the social connection. And even though we're switching to online and we're using Zoom and other platforms more readily these days, we want people to maintain social connections. I think there was a recognition about 2 months ago that social distancing was if we kept using that, people would misunderstand. And we really want them to be physically spaced, not socially spaced. Now,
Right.
Getting people to change a term is hard because it's a habit.
But you're right. It is a better term to apply to the art of separating oneself from somebody else, because we don't want to lose the social side of it.
Right.
What impact do you think COVID-19 will have on messaging for the upcoming annual influenza season?
I think for the upcoming influenza season, it'll be interesting to see. I'm hoping to do a study with some of my colleagues to find out in advance what it'll do. But my sense is that it'll do two things. One, there'll be higher demand for influenza vaccine. And that'll come from a couple things. I think we're going to hear starting in August, a lot of public health experts and doctors and others telling the public, you really should get a flu shot this year because that will help. If it protects you, that's one less illness that you will suffer from. So we'll get a lot of messages to get a flu shot. I think some people will do that on their own volition, that they will say, I think it's just a good idea to get a flu shot because it's better to be healthy than it is to be ill. And I don't, need to have both flu and COVID-19 to worry about. I think we'll also have some group of people, it'll steal their resolve probably not to get a flu shot. That they will look at it as, I'm not worried about any infectious disease. And to be consistent with their stance on COVID, those people may unfortunately decide to be consistent by not getting a flu shot. Now, I think the good news is that'll be a relatively small number of people who would do that. But again, I would also expect that those will be the kind of people who would get some media attention, because that's a story that journalists and reporters could gravitate to, is people who are declaring that they're not going to get a flu shot. And again, that's one of the reasons you see, we as consumers see those things, and it's because they meet the criteria of doing news stories. But overall, I think we're going to see greater demand for influenza vaccine.
Finally, and 2 or 3 different audience members sent in a variation of this question. What 3 or 4 sources can you recommend for factual, accurate info on COVID-19? Where do you go?
Well, I think a couple sources. One is I do still go to the Centers for Disease Control Prevention. And it is true that they had a stumble with tests. But I think that stumble with tests has made them much more cognizant of the importance of having really accurate information. And so I think they have done a really good job, if you go to their website, of providing a wide range of information, a wide range of updates that are very user-friendly. And so I would still highly recommend the Centers for Disease Control and Prevention. I think the other sources I would recommend, there have been a number of media sites that have done a really good job of putting together a lot of information in a very understandable fashion. And they run the spectrum from CNN, Washington Post, New York Times, Fox. So I would say that any media outlet that has made a concerted effort to really build out a COVID-19 resource is probably one that you can trust, because they wouldn't go to that effort and that extreme to make that user-friendly, offer different formats. So I would recommend those. I do think I've seen some tremendous graphics on the New York Times website, including there's an interactive graphic where you can play with the different factors that are involved with producing vaccine to see what that does to the vaccine timeline. So there's like 11 different things that can affect the timeline, and their website actually lets you switch buttons on and off, and you can see in real time, does that make a difference with respect to how fast we'll get the vaccine.
Great. Glenn, thank you. Appreciate so much your insights. And I want to thank the viewers out there as well for spending time with us and for a bunch of excellent questions. We got to some of them. We didn't get to nearly all of them, Glenn. They are a curious, inquisitive bunch of viewers we have. So I wanted to make sure and thank them. I wanted to leave you with a couple of thoughts. One, if you're interested in supporting the work of the college, I would be delighted. We're going to share a link to the Georgia Fund for Grady. One of our questions out there I didn't get to, somebody very astutely asked whether the alumni base is aware of the continued need for support for the work that we do. So I just wanted to underscore that. These days, we're trying to help our students, both undergraduate and graduate students. There's a lot of need. There are a lot of exigent situations out there that we are dealing with as administrators. So we could certainly use your support. And finally, I wanted to remind you all that today's presentation is part of the Ask Me Anything series. There'll be upcoming sessions of this series at alumni.uga.edu. Again, it's been my great pleasure to spend some time with my friend Glen Nowak. Glen, thank you again for joining us.
You're very welcome.